A little more on history taking. We always want to try to make sure that we get a very detailed history from the patient, if at all possible, or people that know the patient or have observed the event from start to finish. OPQRST for our pain, and then sample, which is going to tell us a lot more about their underlying health conditions. If they're unresponsive, you're going to try to get that from somebody else. And if you can't, I mean, you just can't. You're going to have to deal with this and kind of do the best you can with the clues that you have. So some of the significant questions that we're looking for when we're talking about history taking in regards to toxic exposures. First and foremost is, what is the agent? Are we talking about carbon monoxide? Are we talking about some kind of chlorine gas? Are we talking about acetaminophen or ibuprofen? When was the poison ingested, injected, absorbed, or inhaled? Because again, that's when the event started. That starts the time clock versus how much of the particular agent is in the bloodstream and what the effects are going to be. How much was taken? So if somebody says that they've taken, a considerable amount of acetaminophen, we want to know, because there's that LD50, right, which is the lethal dose for 50% of the patient population, and then the ED50, which was the effective dose. And the two numbers can be either wildly different or very narrow in how much somebody can actually take. So it's always in the best interest of the patient, while you're trying to treat them and deliver them to the appropriate facility, that you try to get the best approximation of the actual amount of that offending agent. Is there anything else that was taken? Now remember, potentiation and synergy have big effects in what's going on. A particular drug taken with another drug may allow that drug, such as MAOI inhibitors with opiates, creating some kind of unpredictable effect, right? Or we can have the synergistic effect. So, and then did they take it all at once, or have they been slowly taking this dose throughout the day to the point that it's become poisonous? Has anybody tried to do an intervention? Has somebody gotten that patient to vomit, or has that patient vomited on their own? And then if they have they aspirated the acidic substance in the vomit? What does the patient weigh? Because that's going to dictate what we can give, or what the hospital is going to give in antidote mechanisms. And then, why was the substance taken? Were they taking it for recreational purposes, or was there a psychological component where they were intentionally trying to inflict harm and they knowingly took too much of a substance, or several substances? I'm not going to roll too hard on secondary assessment, because this is part of every assessment. Again, we're going to focus on the areas of the body where the poisoning or the routes of exposure occurred, which is, if it's an inhalation injury, we're looking for lung sounds or breath sounds. If there was some kind of injection, we're looking for multiple injection sites, or if there's any kind of tissue necrosis that's involved with that. And then if it was absorbed, can we irrigate or clear the area of any future absorption? So make sure that you're getting serial vital signs. Make sure that you understand that you're looking for a trend to see if a particular drug or compound is falling within the toxidrome that you're expecting. You want to always watch for your level of consciousness. The mentation of your patient is probably your most reliable indicator of whether or not that patient is degrading or improving or maintaining. So we're going to move into a little bit more of the details of the subject. In this particular slide, we're going to start with alcohol. This is the most widely abused drug in the United States, probably equal to tobacco. Alcoholism is a state of physical and psychological addiction, and alcoholics tend to have chronic malnutrition and will fall frequently. And the reason for the malnutrition is alcohol will actually end up making the patient very unable to actually absorb and utilize carbohydrates because of a vitamin B deficiency. And so they will just ultimately end up malnourished as a result of that. The falls come from the loss of coordination as the patient becomes intoxicated, and they can have many small traumatic injuries. Alcoholism is the fourth leading cause of death in the United States. As you guys understand, alcohol is a powerful CNS depressant. It decreases the activity and the excitement of your particular person who's ingested it. It can induce sleep. It will dull the sense of awareness and slow reflexes, and significantly reduces reaction time. It may cause aggressive and inappropriate behavior because it lowers our inhibitions, and it significantly affects your ability to have full coordination. Some of the medical problems associated with alcoholism will be repeated head trauma, toxic reactions, or uncontrolled diabetes, death from respiratory depression and or aspiration of vomitus. And that's, a patient who is so obtunded, they may try to expel stomach contents just as a means of trying to get rid of the alcohol that's in the stomach. And if they're unable to protect their airway, they can actually aspirate that and get an aspiration pneumonia, which ultimately kills them. Physical dependence and or withdrawals. Alcohol withdrawals are serious business. As a patient withdraws from alcohol, they can end up in seizures, and the seizures ultimately could end up killing the patient. Alcoholic patients also have a very high likelihood of having hepatitis, which is, again, that inflammation, right, the itis of the liver, and then cirrhosis, which is liver damage, and that's fatty kind of nodules that grow into the liver because of the significant damage. It's kind of a scarring, so to speak. Because of the effects of alcohol, you should always consider that they may have some kind of internal bleeding if they appear to be in shock or hypotensive and you're unable to discern why. There's no obvious external bleed. And remember, the GI bleeding or internal bleeding is that scary thing that we're unable to actually see, and so it's usually not really high on our radar, but we should really always be considering that. If the history of the patient indicates that there's a reason for them to have a GI bleed, you should suspect a GI bleed. If they're hypotensive and in shock-like conditions, and you do not see a reason why, like no fever or things of that nature, you should always err on the side of an internal bleed or a GI bleed. We've already discussed that withdrawals include seizures, and the seizures are significantly fatal if not resolved with medications that AEMTs are not able to help to stop seizure-like activity with. In regards to delirium tremens, these patients are literally having a delirious effect as they withdraw. They're hallucinating. The tremens is the shaking and uncontrolled physical agitation of the body. You want to try to keep that patient calm, give them a little bit of oxygen if appropriate, and then if they're hypotensive, we want to give them a little bit of fluid therapy, right? We're just trying to maintain normal blood pressure and keep them kind of talking their way through the situation. Unfortunately, as an AEMT, you don't have the means to kind of sedate that patient who has that delirium or the like. And so the best course of action is always going to be trying to rendezvous with an ALS unit or getting them to definitive care as quickly as possible. Now we're going to roll into narcotics, opiates, and opioids. Narcotics are drugs that are used to produce sleep or an altered mental status. Opiate is the natural drug derived from opium, and if you guys don't know, opium is a product from the opium poppy, which is very closely related to the poppy seeds that you may have on your rolls or buns. But there is a significant difference. Some are bred specifically for the opiate, and some are bred to have no opioid compounds. It's produced by scarring or opening up the seed pod, which a salve will then kind of leak out, and the opiate is extracted from that. Opioids are synthetic, and that would be your fentanyls or carfentanyls and things of that nature, where they're made in a lab. They have the same kind of compounding nature, and they just have a difference in what the drug efficacy is. And so most drugs are in the opioid or opiate world are based off the classification of morphine, morphine being a 1. Codeine, heroin, fentanyl, oxycodone, meperidine, propoxyphene, and then dextromethorphan are different examples of opiates and opioids. You guys can find the chart on what the efficacy of a drug is and how it relates to morphine on the internet. It's freely available, and it's through the DEA. They will show you just how powerful milligram for milligram or gram for gram a particular drug is. Opioids bind with receptor sites in the brain and other tissues. The receptor sites in the brain are the mu or the kappa receptor sites. They can be absorbed through the GI tract or the mucous membranes or even the lungs. In the case of heroin, it can be smoked, injected. It's typically not eaten, but the opioids are typically taken through the GI tract. That's your oxycodone or the hydrocodones and things of that nature. So as heroin passes through the liver, it can still exert its narcotic effects that may actually outlast the effects of naloxone. And you can look up the half-life of several drugs and see which one the half-life is actually longer or shorter in duration than naloxone. And this is the risk of when we make a patient to kind of alert and aware again through the effect of administering Narcan. At that point in our local system, once they're alert and oriented, they are able again to make their own decisions, and they can refuse further treatment if they want. But you want to make sure that you understand, based on what they took, what the likelihood is of that effect having a rebound. So if the Narcan wears off, they could, if taken enough and in a short enough amount of time, if that drug has a long-acting effect, they could go back into that obtunded state. So morphine and heroin produce a euphoric, dreamlike state in most patients, and that's what they're traditionally seeking. And unfortunately, because it's usually an illicit product, they don't know what the dose is from batch to batch to batch, and that's where the overdose actually comes in from, is that they may have used a particular volume of drug for a very long amount of time, but when they get this particular new batch of drug from wherever it is that they get it, it's significantly more powerful, which then overrides where they were going with it, and it puts them into that obtunded state instead of that euphoria. Okay, as we're going through more of the narcotics, some of the things that we're looking for in discerning whether or not that particular patient is using an opiate or an opioid is that they're euphoric. They may have some signs of hypotension because they're in a very relaxed state. More often than not, they will have reduced respiratory rates, right? So they'll have a respiratory depression, and the more strong the drug has been administered, the more likely they are to be in an agonal respiration. Other than Demerol, which is not actively seen very often anymore in the field, most of these patients are going to have pinpoint pupils. And because they're not breathing on a regular rate, the perfusion status of the patient is going to go down, which is going to cause the body to go into a shock-like state. And remember, when we're in that shock-like state, the patient is going to want to vomit. They are not going to divert any energy to creating kind of any kind of nutrition absorption, and so the body will try to void itself of anything that it's trying to digest because it doesn't want it to ferment in the gut. And as that patient is now in that euphoric-like state or obtunded, if they vomit, that again is a new aspiration point. They may be in a coma-like state and eventually go into seizures. So we're going to talk a little bit about Narcan, and in the slide it says it reverses the effects of the opiate. In reality, Narcan just has a higher affinity for the opioid receptor sites, and it will actually just push the actual opiate or opioid off of the receptor site. And so while it is reversing the effect, it's not truly the reverse. It's just taking away the ability for that drug to produce the intended effects. It can be administered IV, IM, or intranasally, and acute narcotic reversal may lead to vomiting. It's not a guarantee. There's a lot of myth in the world that if you give somebody the Narcan dose that's appropriate for bringing their level of mentation back up, that they're immediately going to go into withdrawals. Again, remember that opiate withdrawals are not a life-threatening event. Remember that the intended effect of Narcan is to increase their respiratory rate, and if you can safely bring them back into a alert and oriented condition, that's always appropriate. And then you want to monitor your patient closely and transport promptly if indicated. Again, this varies from system to system to system, but if a patient who receives Narcan is now alert and oriented and able to make rational decisions, they are always capable of making the decision to discontinue your care. And so there's a kind of a fine line that we're treading there with what's the most appropriate thing for your patient. Now we'll move forward into stimulants, and stimulants can be swallowed, smoked, or IV injected. They cause excitement and delirium, tachycardia, hyper or hypotension with a very quick or fast pulse, dilated pupils, and then tremors and or seizures. So stimulants kind of mimic the sympathetic nervous system in its effects, and will cause a euphoria, again, kind of because of that dopamine response to the intended effects of what's happening with the drug, because they may create what's perceived as a hypercognition or a very hypersensitivity to stimulations such as touch or sound or things of that nature. One of the more known stimulants that people tend to abuse is cocaine. It has a local anesthetic effect, and it also has the CNS stimulant. It's quickly absorbed across mucosal membranes, which is why most cocaine is snorted, because it can be rapidly absorbed into the capillary system of the nasal or sinus cavity. And when the effects wear off, the user experiences a crash. So the half-life of cocaine is not terribly long, and as the patients or the persons utilizing that drug experience the half-life kind of kicking in, they have that decrease and that hypersensitivity, and which will resultantly make them seek out more. Moving a little bit deeper into the stimulants, we're going to get into amphetamines. Some of them are legitimate clinical applications. There are amphetamines that are given for persons who have ADHD. There are some methamphetamines, which is a different analog of the amphetamine. Synthetic cathions, which are otherwise known as bath salts, are a recent event that has taken place and has become a systemic public health problem. So some of the very wide, broad strokes of stimulant abuse is a person who has what we would call a wild-eyed or a very hyper appearance facially. They're going to be thin because they're utilizing the drug for energy production instead of actually nutrition. They can appear to be nervous or jittery because of the hyperstimulation of the nervous system. Often they're going to have that inadequate nutrition and very inadequate sleep patterns. And as they fall farther and farther away from the required amount of sleep, they're going to have increasing paranoia and ultimately will end up having hallucinations. Some of the bigger complications associated with cocaine is acute myocardial infarction, and that's because all stimulants are going to create a tachycardia, which is going to increase myocardial demand. And as we do that persistently on a chronic or regular basis, you're actually going to cause damage to the heart because it cannot maintain the ability to beat at such an accelerated rate for such an extended amount of time. They can end up with seizures, stroke because of the hypertension, which will then ultimately cause some kind of apnea or hyperthermia because of the increased metabolic rate caused by the stimulation. Unfortunately, the treatments for stimulants are few in the EMS world, and that's maintain appropriate oxygen saturation levels. We do not have any ability to allow you to give sedation to a patient, but the hospital will sedate that patient to try to kind of counter effect the stimulant. we're going to go ahead and use appropriate vital sign monitoring because we want to see if that patient's trending up or down. And then if we can, we're going to establish IV access and manage any hypotension and make sure that they're getting the appropriate fluids as needed, utilizing all of your tools, and make sure that if they need oxygen, we're going to give them oxygen. Paramedic or ALS intervention has the ability to give that sedation to that patient if they're in some kind of delirium-like state. So make sure that you're always considering that you have an ALS backup or an appropriate destination at a reasonable amount of time. All right, moving forward into marijuana and cannabis compounds. Marijuana or cannabis is usually smoked, and the effects can be observed in several minutes. Smoking marijuana can result in bronchodilation as well as vasodilation, which will ultimately cause some tachycardia. There can be some symptoms because of the effects of THC. The patient will have a euphoria-like state. It can cause some drowsiness, and then it will also cause some diminished motor coordination. The bloodshot eyes are obviously coming because of the vasodilation, which again will cause a little bit of hypotension or at least decreased blood pressure, which will resultantly cause the tachycardia. Management of marijuana and cannabis compounds is usually supportive care. In regards to THC overdoses, as right now, it is statistically impossible for a patient who has smoked cannabis to technically overdose on THC. It would take many pounds of marijuana in a very short amount of time, so it's very unlikely. Now, they may have paranoia or symptoms that they do not like as they have consumed the drug, which would cause them irritability, but we're just going to kind of support them. Before I get into spice, though, we will talk about the new process of obtaining THC, and that's edibles. And edibles, improperly mixed, can cause quite a bit of havoc because the ability for the patient or a child who is much smaller in size to get a significantly higher dose of THC is very easily possible. These patients may get many milligrams of a dose of THC into their system, which again is really hard to say that anybody's actually ever overdosed on THC, but the likelihood of them having a negative experience or increased paranoia is going to compound greatly because of the way that they can concentrate the milligrams of THC into particular edible devices. Now, moving forward into spice. Spice is the term for a synthetic cannabinoid, and this was initially synthesized, and it was very easily created. There was the case of a particular scientist who created the synthetic THC, and as that became popular, they were selling it underneath the term spice or some kind of incense. The problem with this is that the derivatives or the variations of this particular compound changes rapidly. So as every time the DEA comes up with a particular ban on a substance, otherwise known as spice, they will just change a little bit of the molecular nature and then remarket it, because then it's no longer underneath that particular DEA or the government control. And so the government is constantly kind of trying to play catch up with this particular drug. Because of the volatile nature of these drugs being produced and changed on such a rapid amount, we really don't know all of the effects, but it can cause pretty much a lot of psychosis, hallucinations, significant tachycardia, and all sorts of other problems. Spice is one of those drugs that we really don't want to play with. If we know that that particular patient has utilized that compound, we would really want to get them to definitive care as quickly as possible, because again, it's no longer a THC-based drug anymore. These things have just evolved as fast as you could ever imagine, because as soon as the government figures out what that particular compound is, it is automatically placed on that banned list, and then the manufacturer will again change the chemical compound, add something or take something away so that it no longer meets those particular guidelines of being banned. In any case, when you're dealing with a patient who has some kind of spice ingestion or an inhalation, make sure that you're doing your best to get them into the rig and to an appropriate facility as quickly as possible. So now we're going to kind of dive into hallucinogens. In this particular picture, you see a red and white speckled capped mushroom, and that's the Amanita mushroom. It's also known as the Christmas mushroom. That particular mushroom or fungus is thought to be a very high hallucinogen. It's been noted that what different cultures will call medicine men use to experience those hallucinations or trips. And unfortunately, when dealing with mushrooms or other hallucinogens that are coming from a fungus, it is very, very hard to distinguish one type of mushroom to another. Some will produce the effect that are intended, and others are actually quite poisonous. And so this presents itself with a significant problem in the world of dealing with hallucinogens, and then also having that kind of poisonous-like state as well. Other hallucinogens can be LSD. We've already kind of touched on the psilocybin mushrooms, PCP, ketamine, which is actually used as a medication, and then mescaline. Unfortunately, when dealing with hallucinogens, treatment is still, again, supportive. There's really nothing that we're going to be able to do that's going to stop the intended effect of that hallucinogen. We want to make sure that we're not causing them any additional stimulation. And then we want to do transport, and then we're going to be supportive psychologically, right? You're going to be empathetic to what they're experiencing, because typically if you're dealing with somebody who's hallucinating intentionally, the only reason that you were called is because they are now no longer having a enjoyable experience with a particular drug. In regards to PCP and ketamine, we want to make sure that we're administering some oxygen, because in the case of ketamine, you can actually decrease their respiratory rate. And then, if at all possible, you want to establish vascular access. And that's just, again, for more supportive care. Mescaline and psilocybin mushroom users, you want to make sure that you're administering oxygen if necessary, if they're hypoventilating, and give them fluids if they need fluids. But in reality, this, again, is one of those things where we're just doing the supportive care. In any of these patients, if you have anything where they're vomiting, we want to help make sure that we help them maintain a patent airway, so put them in a position and be very quick to help them if they're going into that vomiting state. On to sedatives and hypnotics. Sedatives are used to reduce anxiety, and hypnotics produce the drowsiness and sleep. Sedative hypnotic drugs are CNS depressants, and that's barbiturates and benzodiazepines. In regards to sedative hypnotics like barbiturates and benzodiazepines, these have the potential to be extremely lethal if they've been compounded with alcohol. It's very hard to actually overdose on a particular barbiturate or a benzo as long as the additive or synergistic effect of alcohol is not introduced. Unfortunately, most of these are kind of compounded, and we can have a very risky patient at that point. Airway management is always going to be your priority in these patients, because, again, they may have a decreased respiratory rate and a very high likelihood of actually aspirating if they vomit. This is a patient that you may want to have paramedic backup on, and so again, we're always going to tell you guys, make sure that you have ALS available, and then consider your options. Can you get to a definitive facility quicker than waiting for ALS intercept, or vice versa? Administer your oxygen concentration to help support this, and then your IV access in case they are hypotensive. If they are in a state of shock, you can give anywhere upwards of 1 to 2 liters in a bolus to get their perfusion status back up.